Hey everyone, I'm Nish. I'm an emergency medicine registrar currently on UPI in Australia. So I'm coming to you pre-recorded from Melbourne, here to talk to you about ultrasound-guided IV access. It's a shame we can't meet in person for this event, but I hope you still take away something useful and enjoy the rest of the workshops. So ultrasound-guided IVs are probably one of my favorite procedures. I really find them quite satisfying to do, and I honestly don't understand why anesthetic trainees hate being called about cannulas. I would happily be the cannula service for the entire hospital if I could. So if you plotted a graph of technical skill against risk, peripheral IV access would probably be somewhere in the top left. In other words, pretty low risk, but it can still be quite technically challenging at times, particularly when your target vein's quite small or in a bit of an odd position. Arterial stabs probably a bit easier, as they tend to be pretty superficial, but maybe a little bit higher risk. But central lines are probably a bit more forgiving, even if your ultrasound skills aren't that great, because your target vein's much bigger. However, it is a riskier procedure. But the great thing about ultrasound-guided peripheral cannulas is that they're low-risk procedures that we can practice often in the ED, and also the fine motor skills and hand-eye coordination gained from doing them can really be directly applied to loads of other procedures, including nerve blocks and joint taps and so on. And let's face it, most of the procedures we do these days tend to be ultrasound-guided, and probably rightly so, as it's probably safer and more reliable. So it really is a skill worth learning and mastering, and will almost certainly improve your success and confidence in ultrasound-guided procedures. So I'm going to talk to you about 5 concepts in ultrasound-guided vascular access to hopefully help improve your chances for success. And I hope this will be useful even for some of you who routinely use ultrasound. So starting with selection, I'm going to talk about both equipment factors and choosing the right vein. So your weapon of choice is going to be the linear probe. So high-frequency probes mean better resolution for superficial structures. So this is exactly what we need. So you want to be using a vascular preset, ideally, which will give you better contrast between the vessels and surrounding tissues. You also want to optimize your depth, so reducing it to just below the structure of interest, and that'll maximize the resolution of your image. Next, you're going to need some equipment. So the basics will be something to clean the skin with, a cannula. In most cases, I would be using an 18 gauge IV. So these are usually 45 millimeters long compared to the slightly shorter 20 gauge pink cannulas if you're using Venflons. Where I currently work in Australia, they're actually all the size of a pink Venflon, so they're all 32 millimeter cannulas, but we do stock longer cannulas separately. So you're also going to need some sterile gel, so Optilube will do, and something to protect the probe and maintain sterility. So either a probe cover, although sometimes these can be a little bit cumbersome, so I quite like to use Tegaderm, or even the cuff of a sterile glove will do. If you're using Tegaderm, you can place it directly onto the probe face, or place a tiny bit of gel on the probe before putting the Tegi on, and that'll just create a bit of a fluid medium on the inside and minimize any air pockets. So next you're going to find a suitable vein. So this is an example of a vein in short axis. So you can see that it's easily compressible, relatively thin-walled, and not pulsatile. I usually start looking for veins in the antecubital fossa. Often in slightly larger patients, their veins may just be hiding under some adipose tissues. The medial upper arm is a great site, as the basilic vein is a really nice chunky vessel which would have invariably been missed during the several prior blind attempts at cannulation. And it tends to be a go-to in many IVDUs as well. This does require some specific positioning to improve your chances of success, which I'll come on to later. And the forearm is also worth having a look for because there may be some non-palpable veins hiding under there. If you're really struggling, the neck may be an option. I've definitely used the external jugular or even the IJ in some desperate situations. So what is the ideal vein? So there's actually some literature on this. So a study by Whitting et al. Looked at what the ideal vein size and depth in relation to successive cannulation and found that diameters of 0.4 centimeters or more and a depth of between 0.3 and 1.5 centimeters were ideal. So essentially veins that were more than 1.5 centimeters deep had a higher chance of failure. And this kind of makes sense when you consider the old Pythagoras theorem, because essentially the distance that the needle is going to be traveling to reach the vein is going to be a lot more than just the depth of the vein, and that's going to also depend on the angle of the needle entry. And also you need to consider that at least 2/3 of the cannula is going to have to sit in the vein, or else it will be at risk of tissuing. So this brings us on to size, and size does matter, of the cannula that is. So in general, ultrasound-guided, for ultrasound-guided IVs, the veins are a little bit deeper, therefore you sort of need the length of a 18 gauge green cannula, so you need a sort of a 45 millimeter length cannula for most cases. The standard pink 20 gauge Van Flans are usually a bit shorter at 32 millimeters, but then as you go to larger gauges, they pretty much stay at 45 millimeters in length. This is dependent on the brand though, so check what equipment you use, and if your department stocks longer cannulas, then that's even better. So moving on to position, this refers both to positioning the patient and also yourself and the machine. This is one of the fundamental parts of improving your chances of successful cannulation. So how you position your patient will depend on the location of the vein you're cannulating. So make it comfortable for them, and your patients will probably be a lot more compliant. So rather than hanging their arm off the side rail of a trolley, consider using a rolled up towel or sheet and place that under the arm. And the picture on the right is an example of the ideal position for bacillic vein cannulation in the in the medial upper arm. So you want the patient supine, in this case with the arm abducted to about 90 degrees and supinated. And you can see it's quite proximal in the arm as well. And these are amazing veins. They're usually really nice and plump, even in people who may be peripherally shut down. So in terms of ergonomics, do consider the position of your ultrasound machine. So you want it in your line of sight rather than having to look over your shoulder, such as the picture on the left. On the picture on the right, you can see that the operator has the machine on the opposite side of the patient in his line of sight. And also try and sit down if you can, or raise the bed so you're not straining your back and your neck. So now on to axis and alignment. So there are two main planes in which you're going to be scanning a vein. That's the short axis or the long axis. And the terms in plane and out of plane are also used in relation to performing a procedure with ultrasound guidance. So in plane refers to the needle being guided, in the longitudinal axis of the transducer. So in this approach, you're going to see, you're going to be able to visualize the entire length of the needle, like in the bottom right picture. And in the out of plane approach, only a cross-sectional area of the needle is going to be seen. It's therefore important that you are following the needle tip, or else you will be at risk of going through the back wall of the vessel. Both these techniques have their pros and cons. In general, most people would recommend the short axis technique, as it's probably easier when cannulating smaller peripheral veins, and you can navigate and aim to hit the center of the vessel more reliably. The in-plane approach requires a very steady hand, and even tiny movements can completely alter your view quite drastically. Also maybe awkward in certain places due to the wide footprint of the probe. However, it does give you better visualization of the needle. I'll talk later about how you can combine these techniques to get the best out of both worlds. So now you've found an appropriate vein to cannulate, and you scan the vein in short axis, and you want to center it on the screen. It's important at this point to scan up and down the vein to find its orientation. So not all veins are going to be traveling straight up the arm. Obviously some might lie in an oblique orientation. So if the vein's moving off to the right or the left of the screen when you're scanning up and down, you need to rotate the probe accordingly to align the probe with the axis of the vein until it stays in the center of the screen. So consider using M mode. The M mode line is a marker of where the center is, and this is going to correspond with the center of the center marking of the transducer, and this may help you with needle guidance. So moving on to how to track the needle tip. So sequential needle tracking is crucial to the short axis technique, and it's really the only way to ensure that you don't backwall the vein. So the probe is slightly advanced with this technique when the needle tip is visualized, and then the needle is then advanced further until you see the needle tip on the screen again, and then the probe's advanced, and you repeat these steps until you see the needle tip entering the lumen of the vessel. So here's a video just demonstrating that technique exactly. So you can see the needle advances, the probe advances, the needle advances until you see the needle tip, and they keep going until you see the needle tip in the lumen of the vessel. And that's what sequential needle tip tracking is. At this point, you're going to get a flashback of blood in the cannula, but don't let this distract you. Before you advance the catheter into the vein, you need to flatten the angle of the cannula, advance it a little bit further with ultrasound guidance, and this is to ensure that both the top and bottom bevels of the needle are both within the lumen of the vessel, or else the catheter is not going to thread easily. So finally, the short axis and long axis techniques can both be combined into a 2-axis technique, and this uses the best of both techniques. So in this technique, it involves starting with the short axis technique until you puncture the vessel. And what you're going to do then is you're going to rotate your probe 90 degrees into a long axis orientation to confirm that the needle bevel is within the vessel lumen completely. And then you're going to advance the catheter into the vein under direct ultrasound guidance. This has massively improved my success rates with ultrasound-guided IVs, but it can be a little bit tricky as you need to be able to cannulate with one hand and rotate the probe 90 degrees with the other hand independently. So it does take a little bit of practice, and it is worth doing this on a phantom a few times just to get the hang of it if you're fairly new to using ultrasound. But this has been a game changer for me. So this video demonstrates exactly that technique. So here you see the operator starting in short axis and tracking the needle tip, advancing the probe, advancing the needle until he's in the lumen. And now you're going to see him rotate the probe into long axis. And you can see the entire needle and its length, and you can see that the bevel's through. But now, just to avoid backwalling, he's going to flatten the angle of the needle before threading the cannula over. And the amazing thing about this technique is you see the cannula slide right in, and you can confirm that that cannula is definitely in the vein. There you go. That's how it's done. So just to recap, we've talked about selection of the appropriate probe and depth, selecting an appropriate sized vein that isn't too deep and is an appropriate diameter. Also what equipment you're going to need, and considering what length of cannula you might require. Then we've talked about how you will optimize your patient's position as well as yourself, making sure that your ultrasound machine is in your line of sight. So I mentioned the importance of centering your vein as well, and finding its axis. And M mode can be quite helpful in helping you with where the center is. And then we've also gone through the process of how we're going to track the needle tip in short axis, and then rotate the probe 90 degrees into a long axis to be able to check the position of your bevel and confirm catheter placement in real time. So just a couple of additional things to mention briefly. So the ultrasound-guided ABG or art line. So I find these really helpful, and it actually tends to save me more time rather than digging around with the needle with your patient in a lot of pain. And I've had many patients just terrified of ever having another ABG after lots of failed blind attempts without people using lidocaine. So be kind. And I think a combination of lidocaine and ultrasound really helps, and patients will definitely thank you for it. I tend to use ultrasound as a first line these days for definitely for my art lines, and particularly in shock patients. What about central lines? I'm not going to go into too much detail on this because the principles are essentially the same. With central lines, as I mentioned before, your target vessel is relatively large, so it is pretty straightforward in most cases, except for the fact in this case, you need to be really careful about tracking the needle tip, and this becomes quite important in CVCs because backwalling the IJ might lead you into the carotid artery, and that's not going to be good. So I still use the 2-axis technique for my IJ and femoral central lines, and confirm wire placement in long axis before dilating the vessel. And positioning your patient is going to be just as important, so with the head turned to the side, to the opposite side, and head down if possible. And if you can't position your patient optimally, or they can't lie flat or head down, maybe consider an alternative site like a femoral. So just before you start boshing in some cannulas with ultrasound, there are just a couple of pitfalls I just wanted to recap on. So remember, if the vein is too deep, so more than 1.5 centimeters, consider the possibility of failure or early tissuing of the cannula, and consider whether maybe a longer cannula or a midline or PICC line might be more appropriate. Remember that this is a dynamic scan where you're tracking the needle tip, and this is essential to prevent injury to the back wall of the vessel. Don't get too excited about flashbacks, so remember that the top bevel needs to be inside the lumen, or the cannula is not going to be threaded and it's just going to be bouncing back. So what you need to do is flatten and advance the cannula a bit further, and then use the 2-axis technique to confirm placement if possible. And that's the end. Sorry I can't be there to answer any questions directly. I'm sure my good friend Nick will be hopefully able to cover for me. But feel free to drop me an email or tweet if you like. And thank you very much, and enjoy the rest of the day.